So we are unable to hear you.
Yeah, me, Himangshi.
Yes, sir. So you may start.
Oh, okay. Thank you. Good evening, ladies and gentlemen. On behalf of Conquest family, I welcome you all to this CM. I would like to share a few words about ourselves at first. Next slide, please. Onquest is the largest cancer diagnostic network in South Asia. It is India's leading super specialized laboratory network. Next slide, please. We have pan-India presence with more than 40 laboratories throughout the country and have more than 2,500 service associates. Next. Onquest has 2-decade legacy of trust and accuracy in pathology testing. Over the past 20 years, we have been synonymous with trust and confidence in the field of diagnostic science. Our key business areas are specialized diagnostic like hematology, molecular pathology, flow cytometry, NGS, cytogenetics, histopathology, and IX. Then hospital lab management with partner hospitals and routine diagnostics. Next. We started our journey in 2002 and grew over time. During the course, we got first NABL accreditation in 2010 and CAP accreditation in 2011. Onquest ventured in franchisee labs in 2017. In 2022, acquired 15 labs and launched comprehensive neurology test profile. Next. If we talk about our origin, Onquest is promoted by Burman family, the promoter of Dabur. It inherits strong value, trust, and commitment of Dabur. We follow very stringent quality and have introduced many high-end international technologies to India. Onquest is a leader in the oncology testing, including final diagnosis and reflex testing. We issue reports that inspire doctors' confidence. Next. Our mission is to support some of the biggest decisions our patient ever have to make by providing innovative, timely, high quality medical laboratory services. Our vision is to be recognized as the most trusted Indian pathology laboratory with best in class technology enabled diagnostic infrastructure empowering global relevance. We value collaboration, ownership, nurture, quality, uprightness, empathy, and reliability. Next slide, please. Here is an image of our NRL. NRL has one of the biggest open lab processing area spanning 60,000 square feet. It has state-of-art equipment and accreditation from CAP and NABL. Expert faculties are there having competency to diagnose complex cases. Lastly, Onquest is an established brand name in oncology and specialized testing. We are now aggressively building our retail presence. Next. Next slide. In this new wave of technology, you cannot do it yourself. So you have to form alliances. So today, I welcome you all to the CME. Today, our discussion point is recent insight into B-cell lymphoma and immunotherapy based treatment. We feel privileged to have 3 eminent speakers in our panel. Our first speaker is Dr. Shilpa Modi, Senior Consultant Histopathologist of NRL Onquest Gurugram. She will deliver her lecture on a recent update on large B-cell lymphoma, a pathologist perspective. I request Dr. Modi to get the ball rolling now. Please.
Ma'am, you'll have to unmute yourself.
Good evening, everyone. Are you able to hear? Can I start?
Yes, ma'am. You may start, ma'am.
Okay. Good evening, everyone. I thank all the organizers for giving me an opportunity to present on this forum. Today, I will discuss on recent updates on large B-cell lymphomas as per WHO HEM 5. As we go through, we will get acquainted with the new updated classification of large B-cell lymphomas.
Ma'am, your slides are not visible, ma'am.
Oh. Not visible?
No, ma'am. Ma'am, if you can go on Zoom and try screen sharing again, ma'am.
Okay. Is it visible now?
Perfect, ma'am.
Okay, great. So as we go through, we will get acquainted with the new updated classification of large B-cell lymphomas and the salient features of each entity included under this group. WHO HEM 5 classifies B-cell lymphoid proliferations and lymphomas into 4 categories: tumor-like lesions with B-cell predominance, precursor B-cell neoplasms, mature B-cell neoplasms, plasma cell neoplasms, and other diseases with paraproteins. The topic of today, large B-cell lymphomas, comes under mature B-cell neoplasms. WHO HEM 5 enlists 18 different categories under the group of large B-cell lymphomas. For most of these entities, diagnostic strategies have remained largely unchanged. However, the names of some entities have been modified and there are a few new additions. WHO HEM 4R entity of high-grade B-cell lymphoma with MYC and BCL2 or BCL6 rearrangement, also called double hit or triple hit lymphomas, have been reassigned a name. DLBCL has been added and the BCL6 rearrangement has been omitted, and the new name is DLBCL oblique high-grade B-cell lymphoma with MYC and BCL2 rearrangement. Burkitt-like lymphoma with 11q aberrations has been renamed as high-grade B-cell lymphoma with 11q aberrations. In the entity EBV positive diffuse large B-cell lymphoma NOS designation has been omitted in WHO HEM 5. Mediastinal gray zone lymphoma is a new terminology for B-cell lymphoma unclassifiable with features intermediate between DLBCL and Hodgkin. Fibrin-associated large B-cell lymphoma, previously considered a subtype of DLBCL associated with previous chronic inflammation, has become a separate entity. Fluid overload associated large B-cell lymphoma is a new addition to the list. Primary large B-cell lymphoma of immune privileged sites is a new umbrella term introduced to include primary lymphomas of CNS, testis, and vitreoretina. So I will be describing the rationale behind these changes as we go through each entity. There are other aggressive B-cell lymphomas which are not included in large B-cell lymphomas. Burkitt lymphoma is a separate entity in mature B-cell lymphomas. Primary fusion lymphomas, which was a definite entity in WHO HEM 4R, and HHV8 positive DLBCL, which was a provisional entity in WHO HEM 4R, has been included in a separate group of HHV8 positive lymphoid proliferations and lymphomas in WHO HEM 5. So this list of 18 entities of large B-cell lymphomas seems to be difficult to remember, appears exhaustive. But when we group them as per their common characteristics, it's become easy to remember and we can keep in mind while reporting a case of lymphoma. Some lymphomas are defined by genetic abnormality. Some have unique clinical association. Some are site-specific, while there are others which do not fit into these. So I will be describing the salient features of each entity according to the groups. These lymphomas are defined by genetic abnormality: large B-cell lymphoma with IRF4 rearrangement, high-grade B-cell lymphoma with 11q aberrations, double hit lymphomas, and ALK positive large B-cell lymphoma. This entity of WHO Hem4R, large B-cell lymphoma with IRF4 rearrangement, has been retained as such. There are no changes. These lymphomas are characterized by strong MUM1 expression. So when do you suspect this lymphoma? When a young patient presents with tonsillar enlargement or isolated cervical lymph node enlargement, and your biopsy shows a follicular lymphoma-like picture with co-expression of CD10, BCL6, and MUM1, we should screen for IRF4 rearrangement, as molecular testing is needed for confirmation of diagnosis. This lymphoma needs to be differentiated from pediatric type follicular lymphoma, as they have different prognosis and treatment. Next is high-grade B-cell lymphoma with 11q aberrations. This terminology has replaced the previous entity, Burkitt-like lymphoma with 11q aberrations. This change has been done because studies have shown that molecular profile of these lymphomas resembles more of DLBCL NOS rather than Burkitt. So these lymphomas resembles Burkitt lymphoma morphologically and phenotypically, but lack MYC rearrangement. So if you encounter a case of B-cell lymphoma with Burkitt-like appearance that lack MYC rearrangement, should be tested for 11q aberrations. Next entity of WHO Hem4 entity of double hit and triple hit lymphomas has been reassigned as a name DLBCL / high-grade B-cell lymphoma with MYC and BCL2 rearrangements. DLBCL term has been added to emphasize that some of these double hit lymphomas have a DLBCL morphology. Lymphomas with MYC and BCL6 rearrangement represent a diverse spectrum and have a different genetic profile, and they have been excluded from this double hit lymphomas and are now classified as a subtype of DLBCL NOS or high-grade B-cell lymphomas as per their cytological characteristics. These lymphomas can have varied morphology ranging from large to intermediate to blastoid, and the specific morphology should be stated in the report. These lymphomas have a germinal center-like phenotype. So question is, which cases to be screened for double hit cytogenetic status? So it is debatable whether all DLBCL cases should be screened, but in my opinion, I think all DLBCL cases with GCB phenotype should be screened for double hit status. Also, or TDT negative and cyclin D negative high-grade lymphomas with blastoid or intermediate morphology should be screened for double hit status. Also, overexpression of MYC and BCL2 cannot be used as a surrogate marker, as most double expressors are not double hit lymphomas. WHO Hem5 has retained this term ALK positive large B-cell lymphoma as such. There are no changes. So how can you keep, if you see a lymphoma with immunoblast-like morphology and you see loss of pan B-cell markers and presence of plasma cell markers, always perform ALK IFC for the possibility of ALK positive large B-cell lymphoma. CD30, these lymphomas are CD30 negative, which helps exclude ALCL, which is a close morphologic mimic. Next are the lymphomas, which are site-specific. So before making a diagnosis of the site-specific lymphoma, we need to exclude the involvement by systemic lymphoma. These primary mediastinal large B-cell lymphomas is an defined entity in WHO Hem4R, and there are no changes in Hem5. These patients usually present, these are mediastinal specific lymphomas. Patients usually present with bulky mediastinal mass. Morphology varies from classical Hodgkin or DLBCL. There is absent distant lymph node and bone marrow involvement, which helps exclude DLBCL involving the mediastinum. Also, EBV negative, weak and heterogeneous CD30 positive, and presence of pan B-cell markers helps exclude classical Hodgkin lymphoma. Prognosis is better than DLBCL or mediastinal gray zone lymphoma. Mediastinal gray zone lymphoma has replaced the term B-cell lymphoma unclassifiable with features intermediate between DLBCL and classic Hodgkin lymphoma. It is shown that lymphomas with these features are specific to the mediastinum, hence the change in the name. Cases with similar morphology outside the mediastinum they have a different mutational spectra and are now classified as DLBCL NOS. These lymphomas have overlapping clinical morphology and IHC features between primary mediastinal large B-cell lymphoma and classical Hodgkin lymphoma. Large B-cell lymphoma of immune privileged sites is a new umbrella term introduced in WHO Hem5 to acknowledge common biological features of a group of lymphomas which occur as primary lymphomas in CNS, vitreoretinal compartment, and testis. It includes primary DLBCL of CNS, which was a defined entity in WHO Hem4R, along with primary DLBCL of retroretina and primary DLBCL of testis, which was previously considered a subtype of DLBCL NOS. So these, before labeling it, we should need to exclude the secondary involvement by a systemic involvement. So information on these in these tumors is rapidly accruing. It appears that some lymphomas like of breast and skin, they share some of these biological features. So this group of lymphomas might expand in future. Next is lymphomatoid granulomatosis. It was a defined entity in WHO Hem4R and there are no changes. These are EBV-driven lymphomas, which are specific to the lung. Patients usually present with bilateral pulmonary nodules. It has a unique name, which itself tells its morphology. Lymphomatoid means lymphoma-like, and granulomatosis means it has a granulomatous-like polymorphic infiltrate, and sometimes it mimics reactive conditions. There are variable EBV positive large B cells in a polymorphic background. It has a spectrum of histological grade and clinical aggressiveness, which is related to the number and density of EBV positive large B cells. WHO Hem5 hasn't changed this entity, primary cutaneous DLBCL leg type, which characteristically involves the lower legs of elderly female. This entity needs to be differentiated from primary cutaneous follicular center cell lymphoma because they have a different prognosis and treatment. Intravascular large B-cell lymphoma, there are no changes in WHO Hem5. These lymphomas are extranodal, non-mass forming tumors characterized by a selective growth of lymphoma cells in the capillaries in many organs. They are highly aggressive tumors, partly because of the delay in diagnosis because of protein manifestations of the disease. Now, the next group of lymphomas, which are based on unique clinical association. Out of these three lymphomas, fluid overload associated large B-cell lymphoma and fibrin associated large B-cell lymphomas are a new addition to the list of large B-cell lymphomas. Fluid overload associated large B-cell lymphomas, they commonly involve the pleural cavity and they are associated with an underlying condition causing fluid overload like heart failure, cirrhosis. DLBCL associated with chronic inflammation is an EBV-associated lymphoma, which occurs in the setting of long-standing chronic inflammation. Prototypical example is pyothorax-associated lymphoma, in which lymphoma cells involve the pleural cavity of a patient treated for chronic pyothorax. So these two lymphomas, fluid overload and DLBCL associated with chronic inflammation, they involve the pleural cavities and they need to be distinguished from primary effusion lymphoma, which are HHV8 positive. Fibrin-associated large B-cell lymphomas, they were previously considered a subtype of DLBCL associated with chronic inflammation. Now it has become a separate entity. But compared to DLBCL associated with chronic inflammation, these lymphomas are indolent, non-mass forming tumors with excellent prognosis. They are noted incidentally on surgical specimens excised for various pathologies. The cells are typically found within the fibrinous material of pseudocysts. The other lymphomas, rest of the lymphomas, there are no changes in this entity, T-cell histiocyte-rich large B-cell lymphoma, which have a closer relationship with progressive forms of NLPHL. EBV positive DLBCL, previously it was considered, designated as EBV positive DLBCL NOS. NOS terminology was used earlier to emphasize the exclusion of other EBV positive lymphoid disorders. So before labeling as EBV positive DLBCL, we need to exclude other EBV positive lymphoid disorders like plasmablastic lymphoma, DLBCL with chronic inflammation, lymphomatoid granulomatosis, and EBV positive mucocutaneous ulcer. It was previously called as EBV positive DLBCL of elderly, but now the restriction to elderly has been removed. EBRISH is mandatory for diagnosis, which stains more than 80% of tumor cells. So, plasmablastic lymphoma is a defined entity in WHO Hem4R, and there are no changes in this in WHO Hem5. They are EBV-related immunodeficiency associated lymphomas with plasmablastic morphology, loss of pan B cell markers. Sometimes it's difficult to differentiate from plasmablastic myeloma. Now, the most common type of large B cell lymphoma, diffuse large B cell lymphoma, NOS. It's not a single disease, but rather a group of clinical, morphological, and molecularly heterogeneous group of lymphomas, which do not fit into any 16 specific entities. There are morphological variants, centroblastic, immunoblastic, and anaplastic, which do not have any prognostic significance. There are various phenotypic variants described, like CD5 positive DLBCL, double expresses DLBCLs. But studies have shown that these phenotypic variants have inferior survival, but it has not been validated. ICC has de-emphasized the predictive role of phenotypic variants, but it is still recommended to determine the cell of origin. However, it has been shown that clinical impact of cell of origin stratification is relatively limited outside the clinical trials. On the basis of gene expression profiling, DLBCL is divided into two molecular subgroups, GCB and ABC. 10 to 15% remains unclassified. There are various IC algorithms to determine the cell of origin. Sometimes we get confused with DLBCL, with these terminology, DLBCL NOS and high-grade B-cell lymphoma NOS. So high-grade B-cell lymphoma NOS are aggressive B-cell lymphomas, which are TDT negative, cyclin D1 negative, and have intermediate to blastoid morphology, and we have excluded double hit status. In spite, DLBCL and NOS are lymphomas with large cells, and we have excluded all 16 specific entities. So what's the use of this exercise? But is it important to diagnose specific entity? Yes, because prognosis and treatment differs. Also, it helps in better understanding of the tumor biology, which helps in future clinical research. So is it difficult to classify large B-cell lymphomas as per WHO Hem5? Actually, no. If you have basic panel of IHC markers in your lab, including EBV, IHC, EBRISH, IHC for HHV8, and limited molecular testing like MYC and BCL2 rearrangement, we can classify almost all large B-cell lymphomas. The diagnosis of different lymphomas entity is based on a combination of morphology, IHC, EBRISH, FISH analysis, and B-cell clonality analysis. Recent data from NGS studies have identified 7 genetic subgroups of DLBCL, but the impact of these genetic drivers on the outcome and as a basis for targeted therapy is currently unclear. So as of now, WHO has not introduced any molecular-based classification in WHO Hem5, but it might happen in future. I wanted to share one case which we recently came across. We got a cervical lymph node biopsy for review of a 33-year female. Outside biopsy was suggestive of metastatic carcinoma. Histomorphology showed sheets of large atypical cells with prominent nuclei and moderate to abundant cytoplasm. So we did first panel of IC, LC, and EMA positive. But how CK was negative, which ruled out metastasis. So it was sure that it was a lymphoma. In the next panel, we did pan B cell markers and T cell markers. So all pan B routinely done B cell markers were negative and T cell markers were all negative. So we thought of differentials ALCL. First in our mind, it was ALCL, L positive large B-cell lymphoma, plasmablastic lymphoma. So keeping in mind these differentials, we put another markers. First, we did CD30, which was negative. So 30 negative ruled out ALCL. So MUM1 was positive, CD138 was also positive. So in the final panel, we did more of pan B cell markers and ALK EBV. EBV was negative, which ruled out plasmablastic lymphoma, and ALK positivity and so ALK was positive, which was showing cytoplasmic granular staining. So we give the final impression of ALK positive large B-cell lymphomas. That's all. Thank you.
Thanks, Dr. Modi, for your very informative lecture.
Thank you. Thank you.
Now the session is open for discussion.
So with your permission, we can take the Q&A at the end of all three talks, sir.
Okay, now issue. So our next speaker is Dr. MV Chandrakanth, a renowned hemato-oncologist of Kolkata. He is attached to Narayana Super Specialty Hospital, Howrah, Kolkata. I would like to request Dr. Chandrakanth to share his valuable input on optimal dose of immunotherapy, the untold story. Over to Dr. Chandrakanth.
So, I'm audible? Yeah.
You're perfectly audible, sir.
Yes.
Yeah. So, thanks, Dr. Indranil and OnQuest for this opportunity. I would also thank Dr. Nirmalya for providing me the same. So, it was a lot of learning and a very exhaustive talk by Dr. Shilpi. You know, I learned a lot through varieties of lymphoma after a long time. I remember my UG and PG days. So, just taking a few from there, I will be a little bit saying something about it's not nivolumab, it's one of the debate slides. You know, I just tried to present here so that I need not have to prepare another presentation. So, I am using the same slides again. So, I mean, I will just tell you how dosing of chemotherapy drugs are, how the new molecules of targeted therapy and immunotherapy are dosed. So I'll just go through those finer details. I'll not take more than 9 to 10 minutes. So these are some stories which I have made up, you know, like a person, you know, goes in a desert, you know, gets thirsty and he goes to the shopkeeper to buy water. So he asks only for 10 ml. They say the minimum amount available is 40 ml, which is 40 rupees. And they say that you must take 40 ml. And if you take 240 ml, and if you take 240 ml, you will get 1+1 free. So the person ends up getting 240 ml. That's how it is. And there were more rules to that. So the shopkeeper says that you must drink 240 ml to quench your thirst, and you must keep buying 240 ml whether you are thirsty or not, and whether you are tall, thin, obese. You know, this has some connotations to say that the drugs which are dosed, you know, are not uh, as per kg body weight or are not as per the requirement. They're sort of flat doses, you know. So there are some drugs which are flat dose. Even a 30 kg individual also has to take the same dose. So just to say that those doses are overdosed. So to look into the actual dose of immunotherapies, for nivolumab is 240 milligram or 200 milligram or 3 milligrams per kg is the actual dose in the clinical trials. But there are some trials which have looked at lower dose of immunotherapy, and the lower dose of immunotherapy is from the Indian subcontinent. And because, 100 milligram of immunotherapy costs 1 lakh rupees, the 200 milligram costs around 2 lakh rupees. It's an expensive affair where only less than 1% patients can afford such an expensive treatment. This is some randomized trial where they did compare. You know, instead of 200, they just used 20 milligram of immunotherapy. But remember, they did not compare with standard doses. They just compared with not giving any treatment. They showed that even if you give a smaller dose, you know, 1/10 of a dose of the actual dose, even in those patients, the responses were better and also the survival was better. So that means to say that even a small dose, 1/10 of doses of these drugs also work. Therefore, no need of affording 2 lakh rupees. Even 20,000 also is equally good. Not equally, I can say they are also working. That's what these trials said. But they did have conclusions that only if a patient cannot afford full dose, only then you give low dose. Otherwise, do not give low dose. This was some conclusions. So these are some standard trials, where uh, immunotherapy was used at full dose. In spite of using it full dose, you can see the difference is not that much. You can just see hardly 2.5 months of survival difference. The similar survival difference is what you saw even with the lower dose. Just to say that the lower dose of immunotherapy only sort of is working, 10.1 months is the life versus 7.7 months if I use a standard dose. So you understand we cannot compare two different trials, but look at that. Even a lower dose is also equally impressive. That's what I was trying to say. So, but why don't we have a comparison in the real world? Why don't I compare a 20 milligram versus a 200 milligram? Nobody does it because nobody benefits from it, right? Everybody wants to make money and sell more. So, nobody is going to fund. So, we need to have some investigator initiated studies to actually find out what is the optimal dose. So, there are a few other studies from the eastern part of Asia and also somewhere in the Europe. They also have used lower dose and they're also effective. So now I will just tell you how do you arrive at a proper dose of chemotherapy or whatever drug. When I keep increasing the dose of the drug, uh, the response keeps happening, right? Like, so you have a lag phase and then the response keeps happening. But after a point, even if you increase the dose, the responses do not happen much. So this is a dose response curve. This dose response curve, what we do in chemotherapy is we keep giving the highest dose. For example, let's say paclitaxel, right? So the maximum tolerable dose of paclitaxel, let us say, is 300 milligram per meter square. It's per meter square. It's not a flat dose. You don't have chemotherapy flat doses. You have per meter square for chemotherapies. So give the maximum dose. More is better, above which he cannot tolerate. Because if you give paclitaxel above 300 milligram per meter square, patient will develop neuropathy, or even a bone marrow toxicity happens. So you give as much as the patient can tolerate. Giving more is better. So this is how we come to like a proper dose of chemotherapy. We keep giving the dose up to the dose limiting toxicity. Uh, Once the dose limiting toxicity is achieved, let us say I achieve dose limiting toxicity with 320 milligrams of Pacli, I will go one dose low, 300 milligram will be a recommended phase 2 dose, and that will become the standard for all the clinical trials. So this sort of mentality of giving more is better has been there from times immemorial. Where I give more, I get more effect. So but unfortunately, with drugs like targeted therapies or immunotherapies, um, this funda doesn't work. Uh, uh, this side effect profile, like intolerance, does not happen at all because these are not chemotherapy drugs. They are targeted therapies, they are immunotherapies. So the more you give, the more it works. This does not happen with immunotherapy or targeted therapies. They are just proteins, they are antibodies. Therefore, if I'm able to get the work at 20 milligram, I'll keep giving more because patients do not experience any side effects. So there is a drug like ipilimumab where they went up to 10 milligrams per kg. And then they found out it works even at 1 milligram per kg. And that is the approved dose right now. So, like the dosing of these targeted therapies, for example, bevacizumab, they say we should give 15 milligrams per kg, but we have understood as less as 5 milligram per kg also works. So, sort of this dose limiting toxicity does not happen with targeted therapies. Therefore, If you look into the minimum effective dose and the maximum tolerable dose, the gap is huge. There's a lot of room for the investigator or the company to overdose than what is actually required. So therefore, you must not give a maximum tolerable dose in targeted immunotherapy. So you should give what is called as biologically effective dose. So more may not, more is better probably is not the way to go for targeted immunotherapies. We must not determine dose based on efficacy, but on efficacy, not based on tolerance. So there is something called a Project Optimus campaign. For example, there are so many drugs in the market which are overdosed. You must always come down and say, this is not the actual dose, you're actually overdosing. This is, we are not looking for an MTD, we want a biologically effective dose. So you need to eat how much you can digest or how much ever is required. You cannot keep giving more. And these are some initiatives taken in the West saying the Project Optimus approach to give optimum dose of treatment. So this is some endpoints. So how we look into the efficacy of the drug is by response. We give a drug and we do a clinical trial and we see the shrinking of tumors and we see how long the patient lives. This needs a phase 3 clinical trial. This needs a lot of patients to be recruited, and this needs a lot of usage of drugs, a huge expense. Therefore, we don't, nobody ever dares to do a clinical trial if there is no profit involved in it. So instead of doing these large clinical trials, we must look for surrogate markers like something like a target receptor occupancy and so on, which can be done just by simple flow cytometry. So we must urge for dose reduction, not because of toxicity, but because of effective doses. So there is also enough evidence to say that depending on half-life, the frequency can be altered. And there is enough evidence where molecules are, interchanged with doses and they work equally. So this is some trial which I was saying about Nivo EP. The either doses work. There are randomized trials to say this. And look at the survival curves. Whether you give 1 or 3 milligram, it doesn't matter. The curves are just sitting one over the other. So we should be able to accept the truth that lower doses also work well. Just I was saying what we give is 3 milligram per kg. But you can see the preclinical data. It says that 90% receptor occupancy happens even at 0.1 milligram per kg, and then it plateaus. And the target occupancy, it persists for 3 months. Therefore, you're actually overdosing 28 times than what is actually required. And you see, irrespective of the dose what you give, the response rate remains the same. And these are some examples how even a lower dose of immunotherapy really works well. You can see this huge growth that is there on the left side just melts away and it has become a healthy granulation tissue on the right side. We can also appreciate the CT scan images, the right buccal mucosa, the right neck mass is just, showing excellent response with a lower dose of immunotherapy. So the cost is not 2 lakhs. It can come down as low as 3,000 per month. And, we should be knowing the truth and seeing the truth. But if we believe in lies, it's not right. So to conclude, the terms like ultra low dose and standard dose should be revised to optimal dose of immunotherapy. And we have adequate evidence to say that in a randomized trial, lower dose works well with an excellent hazard ratio. We should be looking at a biologically effective dose and not at the maximum tolerable dose. So we should change efficacy endpoints from response rates to target receptor occupancy and not wait for large trials. So we have sufficient evidence to say that low doses do work, and we must join hands for Project Optimus to urge for dose revision, and optimal dose IO must be standard of care. And it will help to improve access to a lot of our patients. So this is the paper by TMH by Dr. Kumar saying that only 3% patients in India can have access to immunotherapy. But if you can show that even the lower doses of 3,000 per month or 5,000 per month, if you can pay, you can actually improve access to a lot of patients in clinical practice. So with this, I would thank all of you for your patient listening. And again, thank the organizers for the opportunity. Yeah.
Yeah, thanks, Dr. Chandrakanth. for your very valuable input on immunotherapy. Now our next speaker is Dr. Nirmalya Banerjee, an eminent histopathologist of CK Birla Group of Hospital and Narayana Super Specialty Hospital. I would like to request Dr. Banerjee to share the platform to deliver his lecture on molecular profiling of diffuse large B-cell lymphoma. Now over to Dr. Banerjee.
So am I audible?
You're perfectly audible.
Okay, so thank you, Dr. Indranil, and thank you, the team OnQuest, for giving me the opportunity to highlight some important things which are very important for day-to-day histopathology reporting, because one need to know how a DLBCL diagnosis being done and what is the latest classification, because there are a hell lot of changes happened. I will try to summarize in a few slides, but of course the subject is very vast. So I will try my best to summarize the thing. So I will share my slide. Slides are visible? No.
Not yet, sir.
Okay. So now visible it is.
No, sir. If you're facing an issue, I can share the slides from mine.
No. I think.
Okay.
Just a minute. So.
So once you come on Zoom, you can click on share screen.
Okay.
You can click on perfect, sir.
So now.
If you can open your presentation.
Yeah. So now it is visible.
Yes, sir.
Okay. So I'm starting now. Yeah. So first of all, to start with the introduction, I want to mention it very first that whenever you give a diagnosis of DLBCL, you must understand that you are not giving a single diagnosis, because nowadays DLBCL isn't just an umbrella term; it's an empirical diagnosis. So it means a collection of disease which are literally biologically distinct. So when I will end my discussions, you will come to know why I am saying it's very heterogeneous and why they are biologically distinct. So the main barrier to this to introduction of the successful therapy is the genetic diversity. There are a lot of, close to 150 driver genes who are interplay with each other. So therefore, it is very, very difficult for the researcher to specify the therapy, and we are just one step ahead of what we are in 2016. Like we had only one thing in our hand, which is R-CHOP. So we need to go ahead from the R-CHOP, and our classification will help us to just framework or design or interpret the future clinical trial. So this is the skeleton. This is just a skeleton over which we will develop our newer clinical trials, so that we can provide distinct therapy or personalized therapy to each and every patient. So in summary, what I am trying to say, that if you are serious about personalized medicine, you need to take sample from each cancer patient. You need to take EDTA sample. You need to extract the DNA. Then you need to do the targeted sequencing, and then each target-oriented approach needs to be done for each particular patient. Suppose one patient is having MYD88 mutation, he or she has to undergo MYD88 targeted therapy. So this is the key factor of the personalized medicine. So with this knowledge, I just want to start what is the existing strategy for the classification of DLBCL right now, which is the most popular classification is the cell of origin classification or COO classification. So am I audible?
Yes, sir.
Yeah. So am I audible? No? There is no problem.
Yes, sir. There's no problem.
Please carry on. No problem.
Yeah. So if you see the transcriptional subtype, or according to the COO classification or cell of origin classification, we divide into two broad categories. One is GCB, one is ABC. Now GCB and ABC is just 180-degree different tumors. Just 180-degree different tumors because ABC acts in a different pathway, GCB acts via different pathway, and the major distinguishing factor is ABC has a poor prognosis. So many medical oncologists prefer intense immunochemotherapy on ABC patients, but this means nothing. You know, there are a lot of trials, lot of researchers engage themselves to reproduce this classification via microarray or RNA sequencing technology. They tried their level best, but the major limitation is cost, and it is not routinely available in every diagnostic center lab across the world, even if to the developed countries also. So it turned out to be a variable success. So now, as you all know, we have taken a simplified approach, which is you just do 3 IHC markers just to know whether they are GCB or non-GCB. I'm not saying ABC because these protein markers are nothing but the surrogate markers. They are surrogate markers. They are the proxy markers, which ultimately determines from where the cells are coming, whether it is from the germinal center or it is from the activated B cells related markers. So MAM1, we think that MAM1 is possibly an ABC marker. So according to that, we give our diagnosis, but this is just a simplified approach. This classification does not support the actual heterogeneity of DLBCL. So what next? So the next question is what next? Now, the next slide is extremely important. You need to understand this. You think about this circle and you think that this whole circle is high-grade B lymphoma. You think about it. And this greener circle, you think it is DLBCL. So 70% of high-grade B-cell lymphoma is a DLBCL, right? So DLBCL does not mean it high-grade B lymphoma. There are 30% of the lymphoma which are non-DLBCL high-grade B-cell lymphoma, right? Now this purple circle. This purple circle is a MYC BCL2 and BCL6 rearranged lymphoma or DH or TH lymphoma. So now you please try to understand this circle comprises of both DLBCL as well as high-grade B-cell zone. That means it partially overlaps with the DLBCL. Many portion, a fair amount also fits into high-grade B-cell lymphoma, which are non-DLBCL. Now you are getting this, why I am saying it's heterogeneous. Now, according to the recent classification, there are a fair population of DLBCL which are MYC mutant. They are shown, they are carrying MYC driver mutations. So they are MYC positive DLBCL. And this some part of the MYC positive DLBCL also overlaps with the double hit and triple hit lymphoma. Now, in this MYC driven DLBCL group, we classified into two. One is MYC BCL2 positive, which are called double hit signature lymphoma. Number 2 is the molecular high grade or MHG, where no BCL2 mutation is seen. We call this BL signature or Burkitt lymphoma signature. Now this is clear. I hope this is clear by now that why we are thinking about this heterogeneity. This is also a second step. So this is what we had before 2019. 2018-19 up to this, we had this in our hand, but still we are not satisfied because the prognosis is not matching in the longer trials, in the larger trials across the world. So therefore, NCI came into the play, and it has been seen, it has been noticed over years that this double hit signature lymphoma are mostly GCB by cell of origin classification. So now the GCB ABC classification becomes more blurred. So we need to more clarified approach what is going on. So molecular profiling is indispensable if you're talking about precision medicine, because see, GCB acts via chromatin modifier pathway, which I was talking, and ABC acts via B cell receptor pathway. So both pathways are 180-degree different, and there are 150 recurrently mutated protein coding driver genes. Listen carefully, they are driver genes, they are not passenger genes, which have been detected in DLBCL. So it is by far the highest among any other hematological malignancies. So if we solve this, possibly we have solved the major chunk of hematological malignancy. So these mutations, this is extremely important. These mutations are not randomly distributed. So this sentence carries a lot of meaning, because once these mutations are randomly distributed, you cannot classify them, you cannot cluster them. But these mutations are non-randomly distributed, so you can actually functionally subtype them containing those mutational clusters. So with this concept, the three big giants came into the play. Big giants, they are the legends of the the diagnosis of the newer or the coining the newer terminologies. One is the National Cancer Institute, Washington DC. They first published the lymph gene classification. Am I clear? Am I audible?
Yes, sir.
Okay. So this lymph gene classification, they have clustered the DLBCL. They have taken possibly 354 DLBCL cases. So according to NCI, or National Cancer Institute US, these classifications is basically 6 types. One is MCD, which comprises of MYD88 and CD79B mutations, which are on COO classification, which falls into ABC group. BN2, which is BCL6 and Notch2 mutation, will again corresponds to the ABC group. ST2, which is comprises of STK111 and TET2 mutation, which corresponds to the GCB group. EZB, which comprises of EZH2 and BCL2 mutations, which corresponds to the GCB groups, and a smaller thin group of Notch1 mutations. And I want to tell you this point, this Notch1 and Notch2 mutations are mutually exclusive. I will tell you later that once one tumor is having Notch1, it can't have Notch2 mutation. So they are biologically different. And the last group is the A53 group, which is TP53 mutations. And 40% of the tumor, they did not classify it, they call it unclassified. So this is the most, the latest, the lymph gene classifications, and they are the first one to publish their paper. The Stard and colleagues who have, worked for 3 years for this paper, and they came out with this. So these 6 basic classifications by which DLBCL should be classified according to the latest WHO. So this is the first one. Now, Harvard, they also, concurrent to this study, they also published one more paper, which I'll be coming. Now, you see, this MCD group, they act via NFK beta and MYC pathway. Okay. And this EZB group, they mainly act via histone modifier pathway. BNT group act via Notch2 mutations pathway, and ST2 act via JAK-STAT pathway. So now this is clear. That's whatever we are dealing with basically different biologically pathway-based and mutation-based cluster, which altogether we used to call DLBCL, but they are biologically very distinct. This distinction will become more clearer in the further slides. So concurrent to this study, what I was telling, Harvard also published one paper. They took approximately 300 cases, 300 to 400 cases. So according to the Harvard, they believe, these people believe that they also do the whole exome sequencing, but they believe in consensus clustering method. They have done unbiased clustering method, and they have divided it into 5 clusters, C0 to C5. Now this C5 cluster, I want to start with C5, which corresponds to the MYD88 according to the lymph gene classifications. C1 cluster, which corresponds to the BN2 group, which shows BCL6 mutations. Similarly, C4 cluster shows STK1 group and ST2 group and showed STK1 mutation. C3 showed EZH2 mutations, and C2 shows TP53 mutations. And the advantage of Harvard classification is, according to them, this 40% unclassified has been reduced to 27%, which is the biggest advantage. So according to this Harvard group, these 5 clusters actually determines these driver genes alterations. So you need to just tell which cluster it is. Automatically, these, if you say this is, if it's C5 cluster, they will look for mid-88 mutations, and according to that, they will think about the prognosis and the further therapy. So this is the Harvard classification. The main classification is the same, just nomenclature is being changed. Now UK people also, I mean, they also can't sit idle. I mean, they have also contributed a lot in this paper, the latest WHO modifications. The UK Hematological Malignancy Research Network, HMRN group, I mean, they took the largest amount of cases, almost close to 1,000 cases of DLBCL, and they also done the whole genome sequencing. And according to the UK people, they want to call each group according to the most common driver gene mutation, like mid-88. They call it mid-88, which corresponds to the C5 group, which I've already discussed. This Notch2 mutations, which is already according to the C1 cluster, according to the Harvard group, and BN2 according to the NCI classifications. Similarly, C4, C3. What is the advantage of HMRN has showed us that they split this group into 2. Like, SGK1 group, they believe there are 2 groups of SGK1, one is state 2 and one is SOX1, which shows better prognosis. So the basic classifications remains the same. The driver genes have been identified, they have been clustered together. The 3 groups, one is NCI, one is the Harvard, and one is the HMRN. They came out with the similar result, which is very interesting and which is very inspiring also, that yes, we are doing something based on which we can framework our future clinical trials. So this is what the 3 classifications are. Now, what is the benefit on day-to-day practice? I mean, how are they going to benefit our patients? So you see, this is the 3 clusters, and according to them, they have divided it into different color coding. Now, each color signifies or the encodes the typical mutations. Like C1, if you see in Harvard, it will be on BN2, this color will be the same, it's purple, and Notch2 according to the HMRN. Similarly, C4, which is red, dark red, and LymphGen according to it is ST2, and HMRN it will be TET2 group. So they have divided it into different color coding system, and each color signifies one single mutations. Now, what about this? Like, we have different entities in our hand. Now, they came out with different mutations. Now, how to extrapolate this? How this correlation is extremely important. So let us see this slide, which is also extremely important. See, primary CNS lymphoma or primary testicular lymphoma or Waldenstrom macroglobulinemia, they usually originate from the memory B cell or the post-germinal central B cells. Now, this tumor, they have seen classically shows predominantly mid-88 and CD79 B mutations. I mean, these 2 to 3 tumors fall into C5 group. Okay, so they are having worse prognosis. We already know that, and our classification also supports that these 2 mutations are extremely notorious. The 5-year survival rate is extremely low. So somehow we are correlating our data with the clinical data, which is previous data, with previous, the classification, and we are just corroborating how close we are. Similarly, the C3 EZB group, which has been broadly divided into 2. One is MYC mutations positive and MYC negative. So just now we have discussed that a lot of DLBCL show MYC positive. I mean, there is a group of DLBCL which are showing MYC mutations. So those who are MYC positive DLBCL must have C3 EZB mutations, and they will almost always fall into the Burkitt lymphoma group or double-hit lymphoma group. They also carry a relatively intermediate prognosis, depending on the clinical situations or clinical stage. Similarly, the which are MYC negative, they classically fall into the follicular lymphoma group. So if a follicular lymphoma developing to DLBCL, you must get this EZB mutations, and they will be almost always MYC negative. Similarly, as I was telling, that SGK1 mutant tumor or ST2 group or C4 group according to Harvard, they corresponds to the NLPHL or primary mediastinal B-cell lymphoma. And just now our previous speaker has discussed that these are biologically very close tumor and share similar genetic mutations. And you see by this classification that this is also supporting this. So we are very close to catch them. I mean, we have reached so far so that we can correlate with our data. Similarly, I want to mention a very important thing. See, in our knowledge, so far knowledge we are carrying, CLL and mantle zone lymphoma, they are considered as intermediate, grade. I mean, they are not that poorer. But you see, some part of CLL which are showing notch-1 mutations, they are having poor prognosis. So somehow CLL also shares some genetic, features with DLBCL, and that too mantle zone also. So DLBCL does not mean a single disease. It carries it is an umbrella term which encompasses these all. So now by this time you are possibly clear that why I am discussing these exact mutations and the different clusters with each corresponding lymphoma. So I think I am somehow clear to this picture. So what is the implications of prognosis? Yes, this N1, EZB, MYC mutant and MCD groups, which I have discussed, they are always having a poorer prognosis. And these three groups, ST2, BNT and A53, they are having intermediate to good prognosis. And of course, ultimate prognosis depends on the clinical stage and what is the status of the patient to everything. So this all we can also predict the prognosis part. So if we come to the relevance to patient's care, yes, it can give a good information about strong information about the prognosis. It will allow you to selection of the optimal therapy. And of course, the most important part is it will allow us to, a biology-based framework. This is extremely important. The framework, which is biology-based, pathway-based, on which to design and interpret the future clinical trial. So our trials must be designed in that way that, we will blind other groups and we will take the NGS data or whole exome sequencing data and we'll target that patient with particular therapy. And then only we will be able to achieve something, So in the conclusion, I want to say, this classification does not, this classification has no relation with RCHOP. So forget about RCHOP. RCHOP is very old. And you are dealing with DLBCL, that means you are dealing with an utterly heterogeneous disease. And the main purpose is, which has been partially solved, I will say, rather partially, why there are many more things which are yet to come, possibly in the coming papers you will see. We have identified the biology and the pathways related to the lymphoma genesis. So this genomic subtyping will provide us the future framework, and these classifications, which I will say, it will take us to the next further step in the precision medicine journey. So thank you very much for listening, and with this I want to conclude my discussion. Thank you very much.
Thanks, Dr. Banerjee, for very informative and very beautiful presentation.
Thank you.
Now the session is open for discussion. I request audience to share questions.
Hello, Dr. Bhavna, this side from Oncos Laboratories. Thank you, Dr. Nirmalya, for the nice approach, a nice classification and nice presentation. Am I audible?
Yes, ma'am.
You are audible. You are audible.
Hi. I have a question for you, Dr. Nirmalya. It was
Yes.
nice knowing about the molecular classifications of DLBCL, about the Harvard cohort and the clusters which are being followed. I just wanted to ask, is there any recommendation for the molecular testing, that when should it be done? Like, should it be done during the initial diagnosis, or it should be done only for the relapsed and or the refractory cases? Like, what are the protocols which are being followed?
Yeah.
As
Yeah.
per-
See, you see, in India, I mean, if you consider the Indian perspective,
Okay.
the lymphomas are being treated by the medical oncologist in a larger aspect, right?
Mm.
So whatever I have seen, what I have communicated with the medical oncologist, they somehow believe that RCHOP is the bread and butter. I'm just talking about, just to make you understand what is the scenario of Indian perspective. They believe that, if you are thinking about ABC, you give RCHOP plus bortezomib or proteasome inhibitor, but they are still not in a full move to do an NGS on the first go. Rather, they are in a situation to do a PDL1 mutations.
Yeah.
And perhaps you are agreeing with my whatever my experience is. They are doing a PDL1 mutations and giving nivolumab. But in US and little bit of in Europe, the scenario is getting changed after the NCI and Harvard guys published their paper. And they believe that whenever a diagnosis of DLBCL is coming from histopathologist, they have started doing NGS on the first go.
Okay.
Yeah. So in India, it's not yet coming, but eventually it will come. I will tell you, eventually it will come, because many patients I have seen in DLBCL, even if they are doing well, their clinical profile has improved, but eventually the morbidity, the level of morbidity after a few years becoming worse, and they ultimately succumb to death. So we can't go ahead. One side we are publications are going on, and one side we cannot have this picture in our society. So eventually it will also come. One study in AIMS, I must mention, I'm sorry, one study in AIMS was there. I have just reading few days before, 2 medical oncologists, they have shared their data in the DLBCL scenario in AIMS. So they believe if we can do on a government setup, like, for our data and do an NGS of the DLBCL, so they have just started.
Okay.
So maybe in coming years we will get, and we will stratify this, and the trials have been started across the US, targeting these particular groups, and eventually, the finger cross, you can expect possibly within 2 years, the the immunochemotherapies are coming for individual groups. So let's see. Yeah.
Okay, yeah. Thank you, Dr. Nirmalya. So it was nice to know about these groups. Up till now, we are just trying to at least put them to the cell of origin and not going further.
Yeah.
Let's hope that we go that further. Yeah. Thank you.
Yeah, thank you.
Is there any more question from the audience? Okay. One question is there. Question 1. Thank you, doctor, for nice presentation. Kindly throw some light on cost and availability of to know about this mutation in India. Dr. Nirmalya?
Yeah, actually, yeah. So thank you for asking this question. I was also thinking about it. Even see, I have a varied experience when I was, preparing the slides. I want to share some practical views on it. Even the people who are sitting at Harvard, they, after, ending each paragraph, he is writing that there are cost issue, financial issues, there are logistic issues. So you think about India. So, the most wealthy country, they are the industry-based countries, they are having problems because in US nowadays, this mutational burden detection is not coming under the health benefit. So it's getting problematic there. But still the pressures from the researcher side is coming and from the medical oncologist is coming. So in India also, the cost is approximately 30,000 plus if you want to do NGS or whole genome sequencing or whole gene sequencing. I think you will be also, I mean, Dr. Indranil will, since you are working in OnQuest, you will be better person to tell us what is the exact cost of WES in your lab or somehow in any reference lab. What I feel is we need to think about the cost also, and we need to minimize it since it's just the beginning. So I think our government will also think about it, and they will give some subsidies of of diagnosing DLBCL and further subcategorizing them. So it is a very difficult thing to to think in Indian perspective, but eventually I hope so it will come, and we will get the benefit of that. So thank you for asking this question.
Yeah, right. I think there should be some government funding for this high-end test when it starts and in the beginning. Later on, when the number of tests are increased, definitely commercially, these are also variable at cheaper rate.
Yeah.
Yeah, right. I agree with you.
Yeah.
Any more question?
So we don't have any more questions.
Oh, thank you. Also, thank you, speakers and the
Thank you.
audience. Yeah, it was a lovely
Thank you.
seminar and yeah, great learning experience. And audience, I think they have enjoyed a lot. Thank you all. Here I conclude the session and hope to see you again in future. Thank you. Thank you all. Bye.